So this is the thyroid cell, follicular cells here, and this follicular cell has two surfaces. This is the basal surface, and this is the apical surface. This is here is the apical surface, and this is the basal surface against the blood vessels and capillaries. At the basal surface, we have two important structures. This is sodium iodide symphosis, and here is the TSH receptor. Now let's discuss the TSH. TSH receptors and TSH antibodies. I'll discuss its mutation in the receptor later. So TSH, where is it produced from? TSH is produced from the basophil cells of the anterior pituitary. So what are the other hormones produced by the basophil cells of the pituitary? They are ACTH, FSH, and LH. And what are the hormones produced by the eosinophil cells of the anterior pituitary? They are growth hormone and prolactin. And posterior pituitary is just a storage site of oxytocin and vasopressin, ADH. We already explained it in another video on. Then we come to this TSH. Then when produced by the anterior pituitary, what does it do? So the produced from TSH, and TSH is controlled by the hypothalamus, which produces TRH, TSH release hormone. So where does it act? So this is the basal surface. Here we have TSH receptors. TSH attaches to these receptors and stimulates its sodium iodine symphosis to pull more iodine in to produce more thyroxine. So TSH structure has two alpha and beta chain. Beta chain is unique to TSH. Alpha chain is like other glycoproteins. So there may be a mutation in these TSH receptors. It may be a negative mutation or a positive or dominant mutation. If it's a negative mutation, it causes thyroid hypoplasia and congenital hypothyroidism. And then if there is a dominant mutation in the receptor, then it causes hyperthyroidism and thyroid hyperplasia. So this is the TSH mutation. And then we go to TSH antibodies. Two types of TSH antibodies. TSH receptor antibodies. TSH SI is stimulatory immunoglobulin. TSH is stimulatory immunoglobulin, and TSH inhibitory immunoglobulin. TSH stimulatory immunoglobulin causes hyperthyroidism, and it's present in the Graves' disease and thyrotoxicosis. TSH inhibitory immunoglobulins antibodies cause hypothyroidism and present in Hashimoto's thyroiditis. What's the effect of antithyroid drugs on the TSH? TSH remains suppressed for months with treatment with antithyroid drugs. Therefore, it doesn't provide a sensitive index of the treatment. When TSH suppression is alleviated, only then TSH levels can be used to monitor the therapy. Increased TSH increases the thyroid hormone, and this occurs in TSH producing pituitary adenoma. If there is increased TSH production, it will produce increased thyroid hormone. So then we need to do investigation for TRH production from hypothalamus and MRI and a scan of the brain and pituitary. TSH is the most useful marker of the thyroid function. Single test of TSH is enough to assess the thyroid activity. So if there is increased TSH, there is hypothyroidism. And if there is a decreased TSH, then hyperthyroidism. That decreases negative feedback inhibition of pituitary TSH production that causes decreased TSH. An abnormal TSH level is an indication for measurement of thyroid hormone in the circulation. So let's see different conditions where TSH, TRH, and thyroxine increase or decrease. So if there is an increased TSH release hormone, that will cause increased TSH, and that will cause increased thyroxine production. So the defect is in the hypothalamus above, because TSH release hormone is not inhibiting by the increased thyroid, which causes negative inhibition of TRH. But TRH is autonomously produced by the hypothalamus. Second condition, if TSH increases, it will increase the thyroxine, but thyroxine with negative feedback will lead to decreased TSH release hormone. So in this condition, the condition is hyperpituitarism. So in hyperpituitarism, a pituitary adenoma producing TSH, there is increased TSH and increased thyroxine. And in that case, this may become multinodular goiter also. Otherwise, it's homogeneous because of increased production of insulin-like growth factor. Next condition is if there is decreased TSH, that will cause decreased thyroxine, and if decreased thyroxine, that will cause increased TRH. So, in this case, when TRH is increased, TSH is not increased. It should be. So, this is due to hypopituitarism because pituitary is unable to produce TSH despite stimulatory effect of TRH. So decreased TSH and decreased thyroxine occurs in hypopituitarism. And the next condition, if TSH is increased and TSH-RH also increased, TSH release hormone and TSH both increased, but thyroxine is decreased. So this is due to hypothyroidism because when thyroxine is decreased, hypothalamus produces release hormone and pituitary also produces increased TSH, but thyroid is not responding. Next condition, if there is decreased TSH release hormone, but increased thyroxine. So now thyroxine is increased. So inhibitory effect on those causes decreased production of TSH and TSH-RH. So this is due to hyperthyroidism. So what happened to TSH in diffuse goiter? In Graves' disease, TSH is decreased and thyroxine is increased. And in pituitary adenoma, TSH is increased and thyroxine is also increased. So in pituitary adenoma, both TSH and thyroxine increase, but in Graves' disease, only thyroxine is increased, TSH is decreased due to negative feedback inhibition of TSH and TRH. I just already explained it. A rise in binding protein decreases the free thyroxine hormone and that increases the TSH secretion. Now, what are the effects of increased TSH? Increased TSH causes cell hypertrophy and hyperplasia in the thyroid, increase the weight, increase the size, causing goiter, increases the blood supply to the thyroid gland, and increases the blood flow to the thyroid. So, what are the causes of increased TSH? Increased TSH occurs when there is increased TRH, thyroid release hormone, or in cold it increases, it decreases in heat, or increase when there is a decrease in thyroid hormone, when goiter is produced, when there is a sudden rise in binding protein, that causes increased TSH. So increased TSH occurs with TRH, cold, decreased thyroid hormone, goiter, and sudden rise. Hyperthyroidism is the most common cause of pituitary adenoma producing TSH. Now, suppressed TSH levels occur in thyrotoxicosis. With suppressed TSH, with normal unbound T4 levels, measure the T3. So when the TSH is suppressed, measure T4 and T3 because in some patients the T3 is in hyperthyroidism. The T4 confirms the diagnosis of hyperthyroidism, but 5% patients have increased T3. So you have to measure the T3 also. Thyroid antibody, TSH receptor antibodies, we already discussed two types, stimulatory immunoglobulins found in the hyperthyroidism and inhibitory, the second antibodies that inhibit the thyroid TSH receptors, inhibitory immunoglobulins, and they're found in hypothyroidism, they cause hypothyroidism. TSI antibody, stimulatory immunoglobulin, they enter the neonates in the intrauterine life and they cause neonatal thyrotoxicosis. So TSI can cross placenta, thyroxine crosses placenta. So if the mother has hypothyroidism, it may cause neonatal thyrotoxicosis.